Today's episode explores an area of cancer treatment that many people may not fully understand yet, but one that is rapidly transforming how cancer is diagnosed. Joining me today is Dr. Munir Ghesani, Chief Medical Officer at United Theranostics, correct?
Yep.
His work focuses on molecule-level radiopharmaceutical therapies, an advanced approach that allows doctors to see cancer more clearly and treat it with remarkable precision. For patients navigating a diagnosis, understanding emerging treatment options can make a meaningful difference in how they approach their care. And welcome to the Unexpected Detour, Dr. Ghesani.
Thank you. Thank you for
Yeah.
your kind invitation, Francis, and I
Yes, I
appreciate
thank you for your
the
time because
opportunity.
we missed the last time.
Yeah.
So, for listeners who may not be familiar with this area of medicine, could you explain it in simple terms what radiopharmaceutical therapy is?
So the simplest way to put it would be that when you give somebody a chemotherapy or hormone therapy or immunotherapy for cancer, those treatments go through the body, circulate in the vessels, and then they go to everything. They go to normal tissues and they go to the cancers. What that means is that the effect that these treatments cause, chemotherapy or hormonal therapy, is divided between the normal tissues of the body and the target, which is cancer cells. So there are two big problems with that. One, you don't deliver sufficient treatment to the cancer cells, so the efficacy is not as high. And secondly, because normal tissues end up receiving so much of it that there are side effects. So if you look at the patients with cancers who receive chemotherapy, they lose their hair, their bone marrow suffers the effect, so on and so forth. Whereas these treatments, while they are not completely without the side effects, their side effects are considerably less compared to the other therapies. So the way this is delivered is that it's kind of smart targeting. Before you even administer to them, you design these from grounds up and you know your target, and these treatments go and attach to that target. And on the other side of the attachment is the radioactive component. So whatever they attach is what they kill. And since they attach preferentially to the cancer cells, you deliver a lot more treatment to where you need it to go, which is the cancer locations. And as a result, we call it a sink effect, meaning that if you try to dump everything in the sink, there's less on the countertop. So the countertop here would be the analogy of normal tissues, and sink is where the cancer cells are. So if you deliver too much to the sink, then there's not much left to deliver to the normal tissue. So there are two big advantages. One, you kill a lot more cancer cells. And second, the normal tissues are relatively spared.
Interesting. Okay. You answered all the questions. Okay, many people hear the word radiation and immediately feel nervous. How is it targeted through radiopharmaceutical treatment different from traditional radiation? Because this is radiation you're doing, correct?
Correct. Yeah. But this is a
Okay.
smart radiation. And again, as you mentioned, that analogy of sink again comes to play, right? If you are giving somebody an external beam radiation, which is where, they deliver, although those techniques are also getting very sophisticated nowadays, but if you deliver the radiation from outside, anything along the path of that radiation gets the effect of it. So the cancer may be in the center of it, but you have all the things that are surrounding the cancer also get the radiation. Now they try to design it in a way that relatively more goes to the cancer sites and less to the normal tissues. But this one is very injected intravenously, and it is very deliberately delivered to where the cancer cells need to be killed. As a result, you get much less effective radiation to the normal tissue. So while, yes, it is radiation, but it's designed in a way that it is causing the minimal effect on the normal tissues and only goes to the target, which is the cancer cells.
That's awesome. Really awesome. I wish they would have had that when I was going through it.
Oh, they had, I mean, interestingly, the only cancer that had this, in fact, 80 years ago, this was administered for thyroid cancer. And for
Oh,
decades, that concept only remained available for thyroid cancer. But then over the last, especially in US, only last 10 years have been paradigm shifting years where suddenly the recognition occurred, a couple of drugs got approved, and now there are more than 100 different trials going on to apply these kind of techniques and principles in almost every cancer that humans are going through.
so this is a clinical trial that you're doing, or?
We actually are doing a lot of clinical trials, but there are 4 different treatments that are already approved in the US. 2 are for prostate cancer, one is for neuroendocrine tumor, and the fourth one, as I mentioned, more than 8 decades ago, was for thyroid cancer.
Oh, so no breast cancer yet.
Yeah, but it's working. In fact, I just had a patient earlier today for a breast cancer trial. So
Really?
breast cancer, lung cancers, pancreatic cancers, we are all exploring options for these cancers now.
Oh, okay. Because a while back I did a podcast when I came across something and they used light for treatment instead of the radiation. It's some kind of light therapy. I can't
Yeah,
even remember the name of it, but it's some light. Is that the same thing?
no, this is different. So this one, those therapies are not given intravenously. In many ways, our principle compared to chemotherapy and immunotherapy is similar. You just put an IV line and then you deliver these. But the difference comes the moment they are inside the body, is that this is a smart targeting that goes to specifically cancer sites. Now, I have to say that it's not only radiopharmaceutical therapy that are going through these kind of approaches. So there is another approach which does not involve radiation, and it's called antibody drug conjugates. They also deliver more specifically to the cancer cells. So this concept is feasible because more than 20 years ago, the Human Genome Project got completed, and that allowed us to come up with these molecular targeted techniques that are much more personalized for the patients rather than general use for everybody, the same treatment that they get.
Oh, okay. Okay. One phrase we hear more now is personalized medicine. What does personalized cancer treatment actually mean for a patient?
So I'll give you an example of, and this will also relate to the trial that we just started for breast cancer patients, is that the breast cancer patients may have, as you know, they call hormonal therapy, right? So there are various receptors. There's an estrogen receptor.
That
There's a
was me.
okay,
All three. All
all
three.
three. Okay.
Mm-hmm.
So imagine if you are selecting one patient who has all 3 positive, and you are selecting another patient who has all 3 negative, and now there are 2 other patients who have estrogen and progesterone positive, but HER2 is negative, and a fourth patient is HER2 positive, and estrogen and progesterone are negative. Now, if you try to treat all 4 types of patients with just chemotherapy, we know that they are very distinctly different. And same way, if you try to treat a hormone negative patient with hormonal therapy, they will not respond because there's nothing to attach to. So the personalized therapy means that you get the tissue from the patient, you go through multiple different tests and create a molecular fingerprint. And I like the word fingerprint because it is just our fingerprint is very different than others. And so if you create that molecular profile of that cancer and then target the treatment that are specifically meant to target that molecular profile. That's kind of in a simplest term, the example of personalized cancer therapy.
Excuse me. So I guess it was like when I got my diagnosis and the oncologist, she personalized exactly what she was going to use.
Yeah.
Yeah, because she had explained it to me, each thing and what each thing was for. And yes, I did lose my hair, so that was devastating. Well, but she explained it to me, and I did ask her, "Am I gonna lose my hair?" She said, "After the second treatment, that's it."
Yeah. I'm sorry you had to go through all of this.
Yeah, because what was mine? THPC, and then I had to do Herceptin and all of.
Hmm.
So what you do, if it was approved for breast cancer, would probably be a lot easier for a breast cancer patient than to have to go through radiation and the medicines that go through your body, and they really kill all the cells within you.
Yeah, so I mean, there are trials going on. They are still, I would say, even if they are successful, they're still about 3 to 5 years out before they get
Oh,
the approval. So, unfortunately, we do not have any solution for breast cancer in terms of the approval. But on the other hand, for clinical trial, if somebody is interested in participating, there are multiple trials already open and available for patients with breast cancer.
oh, okay, okay. All right. I think you've answered me. I knew you would answer everything.
Oh,
Okay, your work focuses on cancers such as prostate, and it says neurodoctrine.
neuroendocrine, yeah,
Oh, no, endocrine. Okay, and thyroid cancers. That's what you focusing on,
yeah,
correct?
yep. But on the other hand, for the trials, we have lung cancer, breast cancer, pancreatic cancer, esophageal cancer, colorectal cancer. There are multiple cancer types that we have currently clinical trials open for these.
Do you get a
So
lot of young patients in there?
young patients, middle-aged, old patients, unfortunately, cancer increasingly does not spare any age or gender or ethnicity. It is unfortunate that the rates of cancers are not only going higher, but they are covering broader population than they ever did before.
Yeah, I see that from even when I had breast cancer. I was like, how are these young girls getting this?
Yeah,
They're in their 30s. I said I was 60. They're in their 30s and they're coming in there with cancer.
yeah,
And I'm like, wow, you know. And after doing a lot of research, I see a lot of things that we do to our body has a lot to do with this too.
correct. Yeah, that
We
could
don't
very well
take
be the
care
reason.
of the body.
Yeah.
Yeah. Okay. Many patients feel overwhelmed navigating the healthcare system. How does United Theranostics help patients access advanced therapies and clinical trials?
So I hear these comments from my patients all the time. And if you look at the clinical practice profile right now, every clinical oncologist ends up seeing so many patients in a day that they have very limited time available to dedicate to each patient.
Oh,
Whereas in our practice, we call it, one patient at a time approach. And we dedicate an hour to 90 minutes whenever a new patient is seen so that we can not only understand what they are going through, what their body conditions are. We also have very sophisticated scanners so we can create a profile of that patient as we talked about the personalized medicine. So we don't just offer the treatment. We first map out the cancer type and extent, and then we offer the treatment options sitting down with them. Most of the times their family members are also there, which I absolutely admire because when the family gets involved in the care of the patients, the outcomes are always better. Plus, they ask the questions from a different angle that the patient may not have thought of. And
Yeah.
and then so we spend that time, in addition to understanding their medical condition, we also give them specific instructions to follow after the treatment. And then whenever they come for their follow-up, we also dedicate allocated time for them to ask any additional questions that may have come up. So I think what separates us is that we are not only fundamentally trained on imaging, on scanning, so that we understand the patient's molecular profile to personalize their treatment, but we also are spending sufficient and more than necessary time with the patient, hand holding them, giving them instructions, and also becoming their advocates for their care, not only through the insurance approval process, but also working with the other caretakers of the patients in the medical field to coordinate the comprehensive care of those patients.
There's one question I want to ask you, because I know I asked my breast surgeon about how does one get cancer. That's what I mean, that was he explained it to me. So I want to see if yours is the same explanation.
Yeah, so I think it is a very complex interplay between our body, our own genetics, and the instigating, we call it the etiology or the cause. And so you need to have an interplay in your body between those two factors. So if somebody has the genetic profile that is very intact and is able to fight off cancers, it's very common that most of us have the very first seeds of cancer in our body at some point or the other, majority of us. But what happens is our body's T cells and the mechanism that fights the cancer is able to identify it right at the molecular and at the very first cellular level, and it wipes it out before it has the opportunity to grow. If there's something missing in that profile, mutations, then those are not able to fight off the cancers, and those are the circumstances where the cancer grow. Now, if somebody has major genetic mutations, I have seen some of my patients before they turn 40 having 6 different cancers because their body is not able to fight off, and every part of the body starts to create its own cancer type. And I have to say that those are also the most inspiring patients I have because they look at life in a very different way compared to those of us who don't they have not gone through that kind of a circumstance. So that's one genetic profile. The other one is the instigating agent. So if somebody's smoking, those effects of smoking go into the lungs and expose the lungs to become cancer. Now, if these effects are very strong, so for example, if somebody smokes 3 or 4 packs of cigarettes a day, then even if the body's defense mechanisms are robust, these cancer cells will still be forming just because of the sheer load and volume of that smoke effect that's going to the lungs.
Even if you stop smoking, huh?
Yeah.
Really?
Yeah, because the effect may have been there for years. So if somebody says, well, if I smoked 3 packs for 30 years and now it's 15 years since I quit, is my risk of cancer same as anybody who did not smoke? And the answer is no. On the other hand, if somebody smoked only for 5 or 10 years and now they are 40 years out from that risk profile is very different than somebody who smoked for 30 years.
Oh, well, what about the alcohol? Because I see it says
Same thing.
alcohol.
Yeah.
Really?
Alcohol is now linked to several cancers.
So they should have never had passed that law. It's a drug then.
Yeah.
It's a drug that's detrimental to the body.
But especially it's when it is in a higher amount. If somebody
Okay.
is a casual alcohol user let's say, one glass of wine once every 2 weeks. That's a very different scenario than somebody drinking 6 packs every single day.
Oh, okay. I mean, I always wonder because well, you did give me the same answer as my breast surgeon.
Okay,
But
well,
he explained it like your immune system, where some
correct.
people they can get a cold and fight it off, and some people can't, and
Yeah,
because it's the immune system.
yeah. So what I referred to as those T cells are actually the immune systems.
Yeah, because he actually drew a picture for me. He couldn't draw, but he was drawing it out, and it made sense, even though I didn't want to accept it. But then I said, I looked back at the things that I had done with the smoking and the drinking. And although I stopped smoking in 1991 to come out in 2017 to find out I had breast cancer, I was shocked.
Mm,
So, but then I had the dense breast. So I said, I think that has something to do with it too.
that's true too. Plus, if you stop smoking in early 90s, then so many decades have passed that every passing decade starts to decrease that risk. And especially if you didn't smoke heavy and for extended period of time, that's also a different risk profile compared to heavy smokers for decades.
Oh, okay, okay. I wish you were around when my mother had cancer. She had lymphoma.
Uh,
Hmm. Yeah, but I don't think that's hereditary. Or is it?
some of them could be, yeah.
Oh, she had non-Hodgkin's lymphoma.
Depends on what subtype and if there was any molecular profile and the genetic familial mutations were looked for. But yeah, you're right. Majority of them are not familial.
Mm. No, I was just a caregiver, so I wasn't this versed on, any kind of cancer except what she told me because she was a nurse. So
Oh, I see.
yeah. And she just let me know that she knew she had it. And that was it. So she just didn't want to tell me. Okay, what role do outpatient treatment centers play in making these therapies more accessible?
So this is very critical because these treatments are very specialized treatments, and when it started, it was mostly available in large hospitals in inner cities. Now, what I actually worked in those circumstances for 30 years, and I know how difficult oftentimes it was for the patients to navigate through different zones of the hospital. First of all, even before they come to the hospital, many of them would travel couple of hours because they would come from suburbs because there was nothing available in the suburbs, in the communities. That's exactly the reason why we decided to open up multiple such centers in the communities. In fact, we have 4 centers now, and we will be soon having several additional ones in the next year to year and a half. So the advantages are that we are located where the patients are, so it's very easy for them to travel. There's not much in terms of the navigating through the maze. They just come right to the office, and registration is very quick, and they get to see their doctors in a matter of minutes after they walk in. And when they have to come back for their follow-up scans and appointments, having only 10 to 15-minute drive rather than 2 to 3 hour for every single follow-up just adds up a lot of time and anxiety, which is why our model is becoming very popular.
They have to get blood work and all that stuff done too?
Yeah, but we do it ourselves. So we are equipped with that, and that makes it easier because we try to facilitate all their care by minimizing the number of times they have to come.
And they never have to get the port put in. Never.
Well, if somebody has difficult intravenous line, then
Oh,
they can consider port because we
oh,
give
okay.
anywhere between 4 to 6 cycles. They are about a month to 6 weeks apart.
Oh, okay. So then They're like, mine was every 21 days, so I guess it's done like that in
Yeah.
intervals.
Yeah, but it's not as many cycles as generally the chemotherapies have a lot more cycles.
Yeah, yeah, it had a lot. No, I didn't do too much. I only did it for what? It was 6 months, but it was every 21 days. That's what it was.
Okay.
It was the Herceptin that was long.
Okay.
And that was what? Almost 18 months of that. So,
Yeah, that's a longer process.
yes. Are you located in the New York area?
We are located in Princeton, New Jersey.
Oh, okay. So if anybody wanted, they would have to come to Jersey.
Yeah, but it's not uncommon where some of our patients are actually coming from New York because we streamline the treatments, but we also have the trials that are not available in many other places. So it's not uncommon in my practice to see the patients from New York who are coming to Princeton because
Okay.
these trials are not available in New York yet.
So you don't have any affiliation with any hospitals in New York?
I do. I have affiliation with Mount Sinai Hospital in New York.
Not Sloan. Oh, so you know that doctor.
Oh,
Joe Serrano. You know him?
very well. Yeah.
Okay. All right. No. Okay, that's all I'm gonna say. I did go to him, but that's it. And then I went to Sloan Kettering. So that's why. So when we finish, I'll tell you. Okay. For patients listening who have recently received the diagnosis, what questions should they ask doctors about emerging treatment options?
So it depends on the type of the cancer, but yeah, they should always ask the questions about what is this current standard of care, but what are several emerging treatment options. They can also do their homework by going into the government has a website called clinicaltrials.gov, and they can put in their specific disease condition
Mhm.
in the subject and the keyword line, and various trial options would come up. They can then look at the ones that are relevant to them, and when they go to see their doctor, they can actually bring some of that details for discussion. But majority of the clinical practitioners today are very much tuned into the clinical trial options. And increasingly, we find that whether it's in the academic practice or community practice, that the awareness of various emerging treatment options is becoming more and more common. We are at an information age, so it's not so difficult to find this kind of data compared to 30 or 40 years ago when it was not that easy. So they should do their homework, prepare the list of available options, but still leave it to the expertise of their doctor, asking them. They may be aware of considerably more options than what they may have researched and ended up with.
So they have a team, like, I guess because of me, I had a team. I had the surgeon, the oncologist,
Hmm.
and I had a radiologist and a social worker. So they have a team too
Yeah.
of
So we work with a team
healthcare
as well.
team.
Yep.
Oh, it's the same scenario, except they're just not getting the chemo and all of those things, correct?
Correct. Yeah.
Okay. Um,
So what we do is we work with a team that is in the community. So we work with our community oncologists, community radiation oncologists, community surgeons, and provide the care in coordination with all of them.
okay. From your perspective as a physician, how important is the emotional support system for patients during treatment?
I personally think that it is equally important as the targeted treatment that we give. And the reason being that I find over the years of practice that when I see two patients with identical situation, identical cancer, identical spread of the cancer, but outcomes are often different. And I think that there is something to be said about working as a team to address the entire patient rather than just their cancer. So, we look at a patient as a person first and identify cancer only secondarily. And as a result, as I mentioned, we spend 60 to 90 minutes of our time understanding them. And, while that a lot of time is spent on reviewing their scans and their cancer history, we make sure that we allocate sufficient amount of time understanding what their emotional needs are and what their emotional makeup is. Because this way we can, while treating them, we can also address their emotional needs and provide more comprehensive care as a result.
Okay. What gives you hope when you look at the future of cancer care?
So what gives me hope is that in many cancer patients over the years, I have seen the outcomes that are so encouraging. So sometimes you see a patient, and if you look at their, literature wise, it would say they have only 12 months or 18 months to live. I never tell a patient that you only have 12 months to live because, first of all, as I mentioned, there is a variability from person to person. Secondly, these treatments are now transforming the care, not only giving them extended years to live, but also quality years. So they go out. It's not uncommon where I see my patient coming in a wheelchair, and then after only one cycle, they are switching over to the walker, and then another cycle later, they just are using the cane for their support, just to make sure they don't fall up and get hurt. And then after 3 or 4 cycles, you don't even see the cane anymore.
Oh,
And
that's awesome.
so what I like and with the hope is that we not only we call it both qualitative and quantitative outcome advantages. So
Okay.
qualitative meaning, they have improved quality of life, and quantitative meaning we want to give them extended years to live. And we're making baby steps, but we're already seeing some of these trials. So all of these drugs that got approved, the radiopharmaceuticals, have shown improvement in exactly that. Over and over again, the trials are showing that these patients live longer, and they live longer with a quality of life that was better than before they started their treatment. Yeah, so that's where the personalized treatment and the molecular profiles come into play. But even then, those are similar. Oftentimes, the patient's own mindset and their positive energy can make a big difference. And while there is not much data in the literature, in our clinical practice, we find that for sure, that those patients who come in with a positive energy and a very optimistic outlook, they seem to continue to do better.
Oh, maybe that's what mine was.
Yeah.
I came in there with a positive attitude, and I just smiled and hi everybody.
Yeah.
I guess that's how come I did it. But I didn't know that two people could have the same diagnosis. Like I didn't even know what an encapsulated lymph node was. I had to go and look it up.
Oh,
Yeah,
but you
because
made the effort to do that though, right? Yeah.
I had to go and read the pathology report and kind of diagnose those words
Mm-hmm.
and to see what I didn't know I had it under my arm. I was just told it was encapsulated. And that's why I was stage B instead of A. Because I thought I knew everything because I told doctor I was A. She was like, no, you're B. So that's why I didn't know. Now, to end this, is there one message you want patients and families navigating a cancer diagnosis to remember? What would it be if you had one thing, one message?
That message would be that get involved, get the whole family deliberate, and do your research together and find the right resource, because as the options are increasing, it becomes even increasingly clear that what you choose may end up having the impact on the outcome of that given family member. So you need to do tremendous amount of upfront work, do all the research, and then decide which option is the best. And whenever that kind of approach is applied in healthcare, for that, there are a lot of data that show that if the family is involved and then they get engaged with the providers, the outcomes definitely improve. So don't leave everything to the healthcare field or to the doctor, but be partner in the care. That would be my number one message.
Thank you for joining me today on the Unexpected Detour, where in life detours are inevitable, but you never will have to walk them alone. And
Appreciate it. Thank you for the invitation, Francis.